Thank you, Dr. Graner, and we will leave the question session toward the end. Our next speaker.
Thank you very much. And for the next talk, it's my pleasure now to introduce Professor Bassel Abou-Khalil. Professor Bassel Abou-Khalil is very well known in the region. He had visited many countries in Gulf, including UAE. Professor Bassel Abou-Khalil is a professor of neurology and the director of the Epilepsy Monitoring Unit and Vanderbilt University Medical Center, in which he has been a faculty member since 1988 and was the founding director of the Vanderbilt Clinical Epilepsy Center and the Vanderbilt Clinical Neurophysiology Fellowship. He has trained more than 100 fellows in the center, including in the epilepsy and neurophysiology, including our colleagues, Dr. Mohammed Kelani. Professor Abou-Khalil has completed his medical degree from the American University in Beirut, and he has completed his fellowship in epilepsy at the University of Michigan in Ann Arbor, and he pursued further training in neurology in Montreal, Canada. So Professor Bassel Abou-Khalil talk today will be combining anti-seizure medications for rational polytherapy of epilepsy. Without further ado, Professor Khalil will be giving the talk.
Good afternoon. I would like to thank Dr. Al-Kelani, Dr. Inshasi, and the organizers of the symposium for inviting me. My topic today is combining anti-seizure medications for rational polytherapy of epilepsy. I will review evidence for combination therapy versus alternative monotherapy. I will review anti-seizure medication mechanisms of action, pharmacodynamic interactions, and pharmacokinetic interactions. And I will discuss evidence favoring specific anti-seizure medication combinations. In the 1970s and early 1980s, polytherapy was the rule in the treatment of epilepsy, particularly for drug-resistant patients. The combination of phenobarbital and phenytoin was often the initial treatment. But as additional anti-seizure medications were introduced, combination therapies were associated with unfavorable interactions and toxic adverse effects. And the term polytherapy was introduced with its negative connotations. Several studies reported cognitive benefits of converting patients to monotherapy, usually without worsening seizure control, but in general, that didn't make patients seizure-free. With the introduction of many new anti-seizure medications, most of which initially approved for adjunctive therapy, the notion of rational polytherapy was introduced. And in comparison with the older drugs, newer anti-seizure medications were less sedating, had improved tolerability profile, and a lower potential for interactions, making them suitable adjunctive agents. And it was also proposed that perhaps it was the total medication load that resulted in poor tolerability, and that if you combine low doses of two anti-seizure medications, there would be better tolerability. Now, monotherapy continues to be the standard for initial therapy. We have a lot of drugs to choose from. When we choose the first drug, of course, we have to consider efficacy against the seizure type, but additional considerations play a role. And those include comorbidity, the urgency of action, cognitive function, gender, age, co-medication, etc. And of course, we also consider tolerability and safety.